Okay, so this is going to be the first lecture in the neuro series. This is going to be a lecture that is primarily an anatomy lecture. So here's my idea for this particular talk. I'm going to start out by showing three classic skull base anatomy levels, like three particular slides, and that I think are the highest yield that you need to, and I'm going to point out what I think you need to know. Then I'm going to scroll up and down through some series to sort of show you how stuff comes together, because part of the tricky part of doing skull base anatomy questions on a single slice is like orienting yourself. Because when you're reading it for real, it's easy to like, oh, that's the carotid canal because I can see it coming up and vertical, horizontal components, and it's very obvious that that's what that is. But sometimes on a single slice, you can get tricked. It's hard to get oriented. So I'm going to scroll up and down through some images and sort of remind you how stuff comes together. And then I'm going to show you my tricks for skull base anatomy. I've got a few tricks that I think make it easier to remember. Then we're going to review some stuff that's high yield with regard to skull base anatomy besides what is it, which is the what goes through it questions, the ones that I think that are most likely to be asked. And then I'm going to do some similar stuff with vascular anatomy and skull sutures. And that's pretty much it. So let's get rolling. So here's our first slice here. Okay, so I'm going to show you that the yellow arrow is pointing towards that thing, and that is the PPF. PPF is something that you should... so it's pterygopalatine fossa, PPF, and the reason I call it the PPF is, one, because lots of people call it the PPF, and two, that it sort of sounds like a highway to me. I'm going to take the PPF tour. You taking the PPF today? Yeah, I'm taking the PPF. Or a train or subway, something. It sort of sounds like some method of transportation. And that's useful because it is a method of transportation for a lot of stuff in the head. And it's also like a convergence. Like, for example, the thing that the orange arrow is pointing at, that thing, foramen rotundum, sort of looks like an on-ramp or an off-ramp getting onto another highway, right? So the PPF, think about that as like the interstate that different highways hook up to. Next slice here is again showing the PPF, and it's also showing another road that's sort of hooking up to it. This one's skinnier and a little bit more medial, and that is Vidian's canal. It's got a name, somebody's name attached to it that makes it high yield. More posterior and lateral, we've got this thing here, two holes, one that looks oval-shaped, which you remember is the foramen ovale, and behind that is the tinier one that looks like maybe a little spine just got poked through there, the foramen spinosum. Behind that, this is the vertical portion of the internal carotid canal. I show that because I think it's the trickier part of the carotid canal. I think the horizontal component's obvious that that's the carotid canal. I think the vertical one, sometimes people are a little confused on a single slice when they can't scroll. It's sneaky. So that's why that's there. Here's the last case. This is a coronal plane. And we've got orange arrows again and sort of a gold arrow. And the orange arrow is pointing towards foramen rotundum. You may remember that rotundum... That highway, we're going to get there, was sort of heading in this direction like that. See that? So it's like in that horizontal plane. So then you would expect that then when you look at it coronal to be like coming at you. Because before we were taking a cut through it like that, right? So it looked like a highway. Now we're looking at it, looks like we're looking down the barrel of a gun. So that is rotundum, and Vidian's canal is similar. It's just smaller and more medial. Now here's a preview into one of my tricks. This thing here, I'll call this thing the cliff, but it's actually the anterior clinoid process. And when you see that, that is when you want to orient yourself to foramen rotundum. That is like your trigger that, hey, you're showing me foramen rotundum. Plus, there's only so many things you can show on a coronal plane for skull base anatomy, and if you're not sure, I would guess foramen rotundum. If it's going towards you, and if it's going up and down, I would guess ovale, because ovale, you remember you're dropping down through. So let's now, as promised, we're going to scroll, do a little bit of scrolling here. So internal auditory canal, that's pretty obvious usually, right? Okay, there's rotundum getting on to the interstate, the PPF. Horizontal internal carotid canal, that's obvious. Let's take a closer look at this right here. So again, notice rotundum dumps into the PPF, and there's another ramp that's also getting onto the interstate, the PPF, which is this guy, the sphenopalatine foramen. Now, who cares about that? Well, it is sort of near the sphenoid sinus, and that may help you remember that. But I pointed out because there's some pathology that is involved in that general vicinity, which is testable. Now, if you would be shown a mass that was only here, and you would be told that it was a primary malignancy or mass occurring in this region right here, you would think that that would probably be a nerve. Foramen rotundum, as you may remember, transmits the maxillary nerve. Some people call that V2. And so you can get schwannomas associated with those nerves. Now, that's all in all pretty, even though that is the most common solitary mass finding in that location, that in itself isn't all that common. A thing that is a little bit more common is a mass that sort of stretches around like this. And this is, if you're talking about a 15-year-old male with a nosebleed, that is a JNA, right? So juvenile angiofibromas start, so they always show them in the PPF, but they don't start there, and that's the trick, is they want you to say that it originates in the PPF. Instead, it doesn't. Most people agree that it starts in the sphenopalatine foramen and then grows into the PPF. It gets on that road and it drives itself onto the interstate. Who cares? These things are big masses. Who cares where they start? I don't know. People who write multiple choice test questions care sometimes, and that's why I'm showing it. It's because I think that it's just the kind of trivia that people like to ask. Neuroanatomy attendings that I had in residency like to ask that. So, bottom line is, sphenopalatine foramen, it's a thing. It's next to the PPF. It's one of the ramps that's sort of coming from the sphenoid sinus vicinity towards the interstate of the PPF. If you have a mass that's extending there with the very specific demographic of a 15-year-old male with a nosebleed, then that's what you're dealing with. And remember also, these things are super duper vascular. They enhance avidly. They can be shown on an angiogram, enhancing and blushing like crazy. And they're typically fed by branches of the external carotid artery, specifically the internal maxillary or ascending pharyngeal arteries. So now back to the scrolling. So more scrolling here. PPF again. There was our horizontal carotid canal, and vertical portion, see that? See how that can be shown like that? Boom, boom, boom. Getting sneaky there. Now it's just another hole. That's the vertical part. Vidian's canal, foramen ovale and spinosum, like we mentioned before. Some relationships to point out here. Notice that Vidian's canal is medial to all this stuff. Notice that spinosum is lateral to ovale. So you think about, and I'll point this out later, that this sort of looks like the imprint of a woman's high-heeled shoe. She's got her feet turned in, okay? She's got her feet turned in like this way, like she's pointing her feet towards her nose. That's the way to think about it. Why do I bother pointing that out? Because if you're shown in the coronal view, which we'll get to, Spinosum and ovale both run up and down. Spinosum is the smaller one, that is more lateral. So don't mix those up. If I was writing a question, they would be distractors for each other. All right, pointing out something else too, the jugular foramen has two components, and I'm going to talk about this more in a different lecture, but the one in the front is the pars nervosa. I talk about this in the 3rd edition of Crack the Core as the nervous guy in the front. So nervosa in the front, vascularis in the back. So there are two different components. Now let's look at the coronal here. So carotid, that's obvious, right? Now, spinosum, this is this up and down. Remember, it's going up and down, but it's lateral to ovale, which also goes up and down. Notice this thing goes up and down. Vidian's canal is shown sort of running just like ovale, or just like rotundum, more sort of in a, well, if you show it on this image right here, it looks like that it's coming right at you. It actually does have a craniocaudal trajectory as well, but it can look like it's on FOSS. And the thing that I pointed out earlier, which is this anterior clinoid process, pay attention to that, orange arrow coming on. Notice that's when you're seeing rotundum, okay? All right. There we go, PPF coming, all this shit comes together in PPF, see that? It is the interstate. All right, and then yes, greater palatine canal heads into that as well. This little thing right here that you see fractures through sometimes is the infraorbital canal. Little tiny nerve runs through that thing. Okay, so here's my strategy. Here's my tricks. Okay, so the first one is the intersection or the interstate. Okay, so that's like we mentioned before here. Remember, the red one is the spinopalatine, right? There's the PPF, okay, and that is rotundum. So those are the two highways getting onto the interstate, merging onto the interstate. When that relationship is what you look for to orient yourself. And that's really the best way, in my opinion, to find rotundum on the axial view. Okay, next one here is the high-heeled shoe. Okay, so we've got the oval part of the high-heeled shoe, which is ovale, and the spiky part, which is spinosum, color-coded there. That's the way to remember that. And then I think about a gentleman laying down his jacket for a lady as she walks across the puddle. And what is that puddle? That puddle is this. Vidian's canal is right next to foramen ovale as she's walking. She's going to take a step over top of that river. And Vidian sort of sounds like Vivian, which is a woman's name, like the prostitute in Pretty Woman. I believe her name was Vivian. I've never seen that movie. That movie is... I only watch alpha male movies like Transformers because I just need to see shit blow up the whole time. I would not watch Pretty Woman. I read about it on Wikipedia. It's the only reason I know. Okay, so... Or it was a good guess. Never seen that movie. Okay, so moving on. Last pearl here. Key skull base anatomy. Number 3, the cliff. Okay, so there you go. Anterior clinoid process, mentioned it a few times. When you see that, look down and you will see foramen rotundum. And then if you look medial to that, you will see Vidian's canal. How do I remember the relationship between rotundum and Vidian's canal? I remember my alphabet. That's one of the few things I can remember. Even in stress, I can remember my alphabet. So if I'm doing my alphabet, R comes before V if you're headed in that direction. So rotundum and then Vidian's canal being more medial. Okay, so trivia time. So that is the what is it? Now, what runs through it? These make good 2-part questions. These make good just sort of you have to know part 1 to do part 2 questions. So what goes through rotundum? V2 maxillary nerve, or V2. The way that I remember that is the Star Wars character R2-D2, R2-V2, V2 for, so V2 for V2, and R for rotundum. Ovale is the other one. So V3 is is the other one. And another important thing to talk about with this, which I'll get to it here in a second. Cavernous sinus, what nerves? And the better way to ask this is what doesn't go through the cavernous sinus. So a whole bunch of stuff goes through the cavernous sinus. What doesn't? V3 doesn't. How am I going to remember that? How do I remember that? I have too much to remember. This is how I remember it, is that cavernous sinus is going to be up here-ish, like at a different level, obviously, but this is the general line that it's going to be at. So, and here is ovale, and the nerve is going to go, whoop, drop down through that. It never gets to that level, right? So it drops down before it gets to the cavernous sinus, and remember that, then it makes more sense. Okay, so that's skull base. Now, what about the skull? These things, sutures, they close normally for some people and abnormally for other unfortunate people who end up with weird-looking heads, which then results, some of them end up being retarded and some of them just can't get a date to the dance. So the one in the red, let's just do them all here, okay? So if you were doing a CT on somebody and you were doing slices in the coronal plane, you'd have a slice that would go here, and then a slice that would go there, and then a slice that would go. This is my attempt to draw depth. But you know what coronal means, so that one here is coronal, right? Opposite would be true. This is like sagittal cut, sagittal cut, sagittal cut, sagittal cut. So that's the sagittal suture. So those are the easy ones to remember. Then you have to remember the other ones. So metropic is in the front, and I think about that because I think male pattern baldness, sort of like the receding hairline in the front, like George from Seinfeld. Okay, so metropic in the front. Metopic in the front, and then the other one is the other one, lambdoid in the back. So there you go. That's how I do it. So which one closes first normally? Remember, as I said, normally, okay, because remember there's these abnormal closures that can occur and are highly testable because they have fancy French or Latin sounding names. So which one closes first normally? The one in the front. The metopic one closes, so it's the first one that you come to because it's in the front, and that's the first one that closes. Actually, it's this other one that nobody ever talks about or has even heard of. It's unlikely to be asked. That's the technical answer. If you dig around in anatomy books, that's what you'll read. For the purpose of real-life multiple choice, metopic closes first. So which one is the most likely to close abnormally? They can all close abnormally in different patterns. Which one is the one that closes abnormally most commonly? The answer to that is sagittal. Okay, so sagittal kids tend to have long, skinny heads that sort of look like a boat, which is the only reason anyone ever goes into medicine, right, is so they can get their own boat. Let's be honest. You want to get a boat. Everybody wants to get a boat. And the kids tend to be okay with these. They tend to be, like, if they wanted to get a boat, they could probably handle it. They're not typically retarded. They don't typically have hydrocephalus. So what's the French or Latin sounding name for this? There's actually two to make it confusing. The one that's easy to remember is scaphocephaly because it starts with an S. The one that more people will throw around is dolichocephaly, and the one that they will ask on the test is the one that you don't remember because that's how it always happens, so remember them both. Alright, so now we're going to do some vascular anatomy, and I'm going to pretend it's 1950 and I'm going to show it to you in an angiogram and not in a CTA because that's trickier and that's harder. And don't expect mercy. We're not trained to be merciful in this dojo. Mercy is for the weak. Enemy fights you, he deserves no mercy. So, what's that thing right there? That's the first question you want to ask yourself when you look at an angiogram is it an anterior injection or is it a posterior injection? Okay, so you probably know, hopefully, that is the carotid and this is an anterior injection. which means that it's going to be fairly easy to come up with our main branches. So let's take a look at the rest of them here. So let's do okay, MCA first. So MCA is going to come along the side, right? You can so visualize that in your head that if you're looking for the dense MCA sign, that it sort of comes off right to the side when you're looking down at it on the CT, and then M2 and M3 branches come off there. And then the one that goes down the middle is the ACA, or you can remember what an ACA infarct looks like right along the central fissure there. So that's the ACA. Now let's get trickier. I'll show it to you on the side. So the big one on top is going to be the ACA, and again, I sort of remember that because I remember the way that an infarct looks, that you see an ACA infarct first as you're scrolling down, and then as you go further down, then you get into more MCA territories on the sides. So ACA at the top, orange arrow, MCA, next, yellow arrow. Now, here's the other two that I think are most likely to be asked. The one that comes off first and in the front, okay, like it's going towards your eyeball, is the ophthalmic, and the one that's going off the bottom and posterior, like it might be going towards the posterior circulation, is your pecon. So those are the ones to know. So here's a diagram. There's a whole bunch of different segments of the carotid artery that there's multiple classification systems, but this is the most modern one, or the one that most people use. So let me point out some things that I think are relevant. The first thing is this guy, this petrolingual ligament. This is an important surgical landmark, and it's the posterior inferior attachment of the lateral cavernous sinus. Basically, this is where the ICA enters the cavernous sinus. So C2 is a petrous portion, lacernum at C3. C4 people will call the cavernous portion. You can remember that C4 is above this ligament, and that's the cavernous portion. And then C5 is clinoid. So the next thing is this guy, the dural ring. And the reason that this matters, and this is probably more relevant than an important surgical landmark, is that any aneurysm that is above this, distal or more cranial to the dural ring, is in the subarachnoid. So if the aneurysm ruptures, then you get subarachnoid hemorrhage. So 6 and 7 are subarachnoid. Previous to that is not. The other thing is to note, see right where that ophthalmic comes off, right after the dural ring, that's when your ophthalmic comes off. So it's that first branch that they show in the angiogram that's going anterior, okay, and around the same level going posterior is your pecon. All right, so we did anterior injection last time. This we can see the basilar, right? So we know this is a posterior injection, so this is through one of the verts. So let's go through some of these things here. What's that guy? There's one on each side, of course, and it's the big one. That's the posterior cerebral. The little guy right behind him, he is the most superior, and that's your superior cerebellar. This guy here is the AICA, and the one behind that is the pica. Remember that it's possible for a vertebral artery on one side to terminate in pica. That is a variant that's common. And on the other side is another variant here where you have a combined AICA and pica, one sort of branch there. Now, speaking of pica, let's now do a a lateral view, and we see this thing here that has sort of a cranial and a caudal loop. That is the way that they'll show pica. If they're going to show it, that's the easiest way to recognize it, is that it has this cranial and caudal loop, like it's almost like an S there. That's what pica looks like. All right, let's do some variant anatomy that's common. So this thing here has a special name. You may remember that this is called a fetal PCOM. Why did I call it that? I called it that because the posterior communicating, this guy, is the same size or bigger than this guy here, okay, which is P1 segment, PCA. So anytime you see that, that's a fetal PCOM. Who gives a shit? Well, if you had a stroke and it was ICA, is here in this region here, it's possible to have a stroke that involves both the MCA and PCA distribution on the same side. And that could be a sneaky way shown on diffusion to infer that there is a fetal PCOM. Also know that this is very common, like 30% of people have it. You see it all the time. Here's a less common variant. Let's take a zoom in here. This thing. And what this is a communication between vertebral basilar system and the carotid. This is actually normal in the developing fetus, but it usually goes away. So some people call this a persistent, meaning that it's a persistent fetal thing, trigeminal artery. And it's actually the most common connection between the vertebral basilar and carotid systems. So that's one piece of trivia to know. Another piece of trivia to know is that it's prone to aneurysm. Okay, so anatomists will describe these things as either intracellular or extracellular, depending on their pathway, lateral or medial. And another thing that you need to know is this sign. Anytime there's a sign that sort of makes it easier for people to show. This here, some people say looks like a T, and that's the supposed tau sign. It's just that vessel coming off from the carotid into the vertebral basilar system. So here is a list of all the different communications you can have between the carotid and the vertebral basilar system. And I'm just pointing out that obviously posterior communicating is the normal one, and then more inferior to that is the trigeminal. It's the most superior, and it's the most common of the persistent fetal communications. Now, there's a whole. I listed some other ones here. I'm not even going to mention them, except for hypoglossal, which is the second most common. Usually occurs somewhere between C1 and C3. The rest of these are just on here for show. Otic is some people say that one doesn't even exist. All right, so last thing here is some venous anatomy. This is a delayed neuroangiogram here. So this thing here, it's obvious, right? Superior sagittal. This is the confluence here as they come together. Now these are the ones that, if you haven't reviewed this in a while, you might mess up. Transverse and sigmoid, and you may remember that drains into the jugular vein. Okay, so that's the end of part 1, and we'll continue on with some T-bone pathology and anatomy in the next Neuro Talk.